Hello and welcome once again to Best of the Day from the 50th annual meeting of the American Society of Clinical Oncology, meeting once again in Chicago. I don't think I can remember an ASCO in Chicago with better weather than this year. It's been sunny and lovely almost the entire time we've been in Chicago. This is Tuesday morning, the final day of ASCO, and we're finishing up these Best of the Day programs. But right now we're sitting down with Dr. Ann So, a thoracic oncologist from MD Anderson Cancer Center, and talking about some of the interesting abstracts from this year's meeting in local regional non-small cell lung cancer, small cell lung cancer, and also head and neck cancer. So Ann, welcome to Best of the Day once again.
Thank you.
Well, thanks so much for being with us. And there was some very important data presented at this year's meeting. And one of the trials that everyone has been really looking forward to was the RADIANT study. And this was a large phase 3 randomized double-blind trial looking at the use of erlotinib in the adjuvant setting in post-resected stage 1B to 3A non-small cell lung cancers who were EGFR overexpressed or amplified either by immunohistochemistry or by FISH, although there were some patients that were also EGFR mutated. So tell us about the study, the results, and then what else they had to say about the EGFR mutated group.
Absolutely. So this was a very important study because it had the capability to potentially alter the way we do of care therapy in the adjuvant setting. Now, the bottom line to the large intent to treat population was that there was no progression-free or overall survival benefit for the intent to treat population. However, when you broke it down and you looked at the EGFR mutant population with sensitive mutations, deletion exon 19, L858, these patients did have a progression-free survival benefit, although there was no overall survival benefit. Now, when we look at the RADIANT study, we have to also think about some of the other trials that have been looking at use of adjuvant therapy as well. There was a retrospective study from Memorial Sloan Kettering which showed the same thing, progression-free survival benefit with use of adjuvant erlotinib or EGFR TKI. And then also in the study SELECT, they also showed a progression-free survival benefit. But there still, to date, is no overall survival benefit in these patients.
And these patients, many of them also got adjuvant chemotherapy except for stage 2 and the 3A. So the erlotinib was added post-chemotherapy.
Yes. Absolutely.
So why was it that they chose patients who were EGFR overexpressed or amplified as opposed to just focusing on the mutant group?
Right. So the mutated group is a very small population of patients. And so at the time these trials were designed, they still had not elucidated exactly the exact mechanism by which EGFR TKIs work. So there still was some thought that may have benefit in EGFR overexpressors or the gene-amplified population. And so back when this was designed, they were going off of their initial impressions.
And there is some evidence from some of the maintenance trials and BR21, I think, that erlotinib had some activity.
Activity in wild type, absolutely. Right. And there are some additional prospective studies that are underway that are going to be looking at this population particularly. Alchemist trial is one that we're highly encouraging people to put patients on because we still need prospective randomized controls trials with larger numbers of patients to really know whether we should be changing our standard of care in this population. As of today, I would not recommend doing this off a clinical trial.
So if you're referred a patient who is a stage 2B EGFR mutant and they get 4 cycles of adjuvant chemotherapy, hold the erlotinib until there is definite evidence of a progression?
Yes, I would do that because, again, we still do not know enough about this to make that change in clinical practice.
Very good. Well, there's also a couple, I think, very interesting studies in extensive stage small cell lung cancer. Of course, these patients have a tough outlook as it is.
Yeah.
Most of them will respond to cisplatin-based chemotherapy, but they frequently recur, often within 6 to 8 months. And there's always the question as to what more can you do to try to prolong their survival, maintain their quality of life. Are they going to benefit from radiation to residual disease in the chest? Are they going to benefit from prophylactic cranial irradiation like we frequently do for the patients with limited disease? So there were a couple studies looking at those topics. And tell us a little bit about those studies and what their conclusions were.
So let's talk first about the prophylactic cranial radiation, because that has been established as a standard of care practice in extensive stage disease patients who have a complete response or close to complete response. There was an NEJM paper that came out by Slotman et al. Demonstrating that PCI seemed to improve overall survival. Now, what we saw at ASCO this year was a Japanese study. Now, unlike the Slotman study, the Japanese study had baseline MRIs and surveillance in these patients with extensive stage small cell. And they were monitoring these patients as well. And so what they demonstrated in this Japanese paper was that prophylactic cranial radiation did not improve overall survival in extensive stage small cell lung cancer. What it did do, though, is it did improve neurologic symptoms. And then in terms of progression in the brain, it did delay that.
It did delay.
So we do see some clinical benefit there, but not the overall survival benefit that we saw with the Slotman study. And that may be attributed to the monitoring practice that was done here, which is probably more consistent with what we do here in the United States.
So are there any clinical or pathologic factors that would make a patient more likely to relapse in the brain first and perhaps lead you to consider PCI in a particular set of patients as opposed to the general population?
You know, I haven't seen that there's any predictive or prognostic factors. It mostly is the bulk of disease. If this is a patient who has pretty widespread disease, their odds of having brain dissemination are higher. But, you know, if they are very sensitive to chemotherapy, as many of them can be, and you establish a complete response in the body, you're left then now with a decision about whether or not you want to do prophylactic cranial radiation. And I think it's a little less clear now if they have no documented evidence of brain metastases. And so this Japanese study has lent some hesitation now, whereas before, I think after the Slotman paper, everybody was moving towards PCI.
Right.
Now, Slotman did also present oral presentation today, yesterday, looking at thoracic radiation as consolidative therapy. And so
in extensive stage.
In extensive stage disease. So in patients that had an excellent response to therapy, they basically administered consolidative thoracic radiation. And they demonstrated that although within the first year there was no overall survival benefit, they actually demonstrated when you get 18 months out, you do see this, you know, survival benefit in the patients who got consolidative thoracic radiation. So I think it's actually interesting. I think we're seeing a difference in the natural biology of the disease. You know, the patients who tend to be more sensitive to treatment, both chemotherapy and radiation, obviously have the best outcomes. But there's clearly a population that do seem to benefit from consolidative systemic radiation.
So it's not just that the population that benefited was going to do better regardless of whether or not they got radiation. You think the radiation really made a difference?
I actually am inclined to think that. In my clinical practice, in our patients who have not widespread disseminated disease, but fairly contained extensive stage disease where they're borderline limited, but they have like an adrenal met or a solitary liver met, in these patients, if you give them a great response to systemic therapy, you can go back in and consolidate, radiate those sites, and sometimes you can achieve significant prolongation of their progression-free survival. If not, sometimes, you know, they don't need to worry about this for several years.
And how well is the thoracic radiation tolerated in patients who have already gone through 4 cycles of cisplatin-based chemotherapy?
It actually is not bad. I mean, you know, we do this in limited stage disease, and we do this oftentimes in non-small cell when we need to palliate the patient's symptoms in the lung. And so, for the most part, these patients do very well.
Good, good. Well, let's let's talk about head and neck.
Okay.
And there wasn't a great deal to talk about at this year's meeting, but one of the things that we've talked about several times in the past is the human papillomavirus positive population. And these are frequently younger patients, non-smokers, more commonly males than females, and primarily oropharyngeal disease.
Yes.
They have a better prognosis. They respond better to systemic chemotherapy. And the question has been, do we need to treat these people as aggressively as we would the typical oral squamous cell carcinoma in somebody who's a heavy drinker, heavy smoker, older patient with a worse prognosis? So this study looked at whether or not you can decrease the amount of radiation. So
Yes.
tell us a little bit about what the design of the trial was.
So the ECOG trial was actually designed with all of that in mind, because we do know that these patients have better response rates, better outcomes, and so let's try to limit their long-term toxicities from concurrent chemoradiation therapies that we've had to use in the past. So what this was doing was looking at a dose reduction in the radiation therapy in the patients, specifically HPV positive patients. And so I believe they went down to 54 gray. And this was, of course, after...
As opposed to 70.
Yes, and this was, of course, after they had received systemic chemotherapy. And then they had, a response to treatment, and they had close to CR responses, is what I understand. Now, what they actually found out from this was that the, tumors that were small, T1, T2, small nodal disease, those actually did very well, and they did not have significant recurrences. But if you actually see the larger tumors, T3, T4, bulky N2 disease, N2C disease, those patients did not do so well with the dose reduction in therapy. They did have local...
Frequently, these patients present with bulky adenopathy.
They sure can. Oftentimes, these patients will have N2C disease. So in the case of the dose reductions, most of the patients who had large tumors or bulky and nodal disease, they ended up having local regional recurrence as well as distant metastatic disease. And so the dose reductions, I think, are a definite possibility for the smaller tumors, earlier stage tumors, less nodal disease. However, I think the larger ones still need to have significant research in terms of...
So if you have more limited disease and you get at least what appears to be a clinical CR from induction chemotherapy, then you may be able to give a more reasonable lower dose of IMRT.
I think that can definitely be considered to limit their long-term toxicities. But right now, we don't know which population for certain needs to have that done. So we do need additional research before I think it's completely adopted as standard practice.
Good. Well, let's talk a little bit about thyroid cancer. Over the last few years, especially in the well-differentiated thyroid cancers, there's been a tremendous amount of excitement over the use of small molecule tyrosine kinase inhibitors. Sorafenib has been looked at extensively and is approved for the patients who are iodine refractory, I-131 refractory. But there have been a number of other agents in the pipelines. Everolimus has been looked at for relapse disease, and now this Eisai drug, lenvatinib, is presented, and this was a fairly substantial phase 3 trial. Some of the patients had previously had TKI exposure.
About 25%.
Right, and some had not. So how active does this agent look?
Well, I have to say it was pretty remarkable. There was such a significant increase in progression-free and overall survival benefit. And again, they are comparing it to placebo. Right. But I believe it was close to a 14-month, improvement. And so this certainly makes sense because we know that this disease is sensitive to the anti-angiogenic TKIs. And of course, lenvatinib being a target for VEGFR, PDGFR and FGFR, certainly, fits the bill in that case. So I do think that this is a very important study. In terms of adoption into practice, it makes sense. This is a very angiogenic tumor that appears to respond, and the survival benefit is there as well.
So sorafenib can be kind of a rough drug to take, especially in the like the first year that you're on it. And I know in sitting down with Marcia Brose from Penn, who's done a bunch of these studies, she has a very strict prophylactic protocol and is very careful about trying to reduce adverse events. How does the adverse event profile for lenvatinib appear?
It appeared to be fairly well tolerated. Most of the side effects would be what you would expect with this population. There's a very small rate of thromboembolic event, but I believe it was very small. And then fatigue, of course, is a problem, but with any treatment, we do expect that. I think the adverse events certainly are worth the benefit in terms of progression-free and overall survival, though.
Very good. Well, let's move on to the final topic, and probably a dominant feature at this year's ASCO meeting, and that has been immuno-oncology. I mean, there's been tremendous excitement over the past 3 or 4 years over immune checkpoint inhibitors, the PD-1, PD-L1 interactions and pathways. And this year we saw one of the first presentations that I remember in squamous cell head and neck cancer with the use of MK-3475, or what is now called pembrolizumab, I think. So we know what the rationale is of interrupting this interaction between the malignant cell and the activated T lymphocyte, but how significant a role does this appear to play in head and neck?
Right. So I would say immunotherapy is definitely going to have a significant role across all solid tumors. But the trick is figuring out which patients are most likely to benefit. So this agent targets the ligand, the PD-1. But it definitely affects both PD-L1 and PD-L2. So what they did in this study is they required that all the patients who received the MK-3475 have at least PD-L1 expression by immunohistochemistry. Now, it was pretty open. You had to have at least 1% staining. But they found out of the screening, roughly 78% of the head and neck squamous cell carcinoma patients had some staining of the PD-L1. And they had a bimodal distribution of the immunohistochemistry. There were some patients who had significant expression, and then there were those that had fairly low expression. And it's interesting because when you look at the efficacy outcomes, they didn't present progression-free or overall survival yet, but they did show response rates. And they still have quite a few patients that are still on this trial, but there was a bimodal distribution as well in terms of responses. So those who had higher PD-L1 expression by immunohistochemistry had significant shrinkage of their cancer from the MK-3475. So I think that this is a very active drug in head and neck squamous cell, but you have to identify the population that can receive it, and they have to do a cutoff of the immunohistochemistry to determine those patients.
And I've heard some people say that cancers that are basically genomically dirty, that they have lots and lots of mutations, are more likely to benefit because they appear so abnormal to the immune system, as opposed to a cancer that only has like one oncologic driver, like chronic myelocytic leukemia or something like this. So squamous cell carcinomas, heavy smokers, heavy drinkers, are bound to be fairly genomically unstable with lots of mutations.
So I do think that that is one theory that we may see pan out, but if you actually looked at this study, the HPV positive tumors theoretically have less genetic mutations as those who are non-HPV. And what we saw is there was no difference between the HPV
really
positive and the HPV negative patients.
Really
it all really depended on their PD-L1 expression by immunohistochemistry.
And that seems to still be very controversial, as to, since some of the PD-L1 negatives seem to respond.
Absolutely.
Lower percentage, but definitely responsive.
So I think we still have a lot of research we have to do. There is a signal there, and I do think that the immunotherapy agents are probably not only going to be looked at as monotherapy or as maintenance treatments, but in combination with the different targeted therapies as well as potentially chemo.
Has there been much work done with the anti-CTLA-4 antibodies in head and neck?
Not that I'm aware of, but I do know the anti-CTLA-4s. There was a tremelimumab trial in mesothelioma that was presented. They are certainly also looking at it in lung cancer. They also have combinations of the PD-L1 and the CTLA-4 inhibitors that are currently ongoing in trial.
Right. Yeah, we've seen some of that with in the melanoma studies, and also very interesting. Well, Anne, anything else that struck you at the meeting this year?
Well, I think it was very exciting with the ALK inhibitors. The second generation ALK inhibitor, ceritinib, just got FDA approval. Right. Certainly we have FDA breakthrough designation for CO1686, which is a unique EGFR inhibitor specific to the EGFR mutants. Yeah. And then AZ9291, of course, as well. So I think the next year will be very exciting as we see some additional results come out in our small mutant populations of lung. And certainly a lot of the next-gen sequencing profiling work that's being done has identified a whole host of new mutations that we can potentially target.
We're going to break that disease down into multiple little categories.
I'm hopeful. I'm hopeful.
And hopefully we'll have active agents for all of them.
That would be
Anne,
great.
thank you so much for coming by. I know you are probably anxious to get home after a long and very busy, exhausting week here in Chicago.
It's always been such a pleasure to work with you.
Well, thank you very much, and for me as well. And thanks to all of you for watching this segment of Best of the Day. There is more to come. Dr. Govindan will be here shortly to talk about some of the abstracts in metastatic non-small cell lung cancer. And Dr. Axel Grothe will also be by to sit down with us and talk about GI malignancies. So be sure to check back. Thanks again.